So I guess we are live now. Good evening, everyone. The Bangalore Society of Obstetrics and Gynecology and Omnicurus welcomes you to the scientific talk show wherein Dr. Tejavati and Dr. Sushila will uncover the challenges in diagnosis and treatment of PCOS in adolescents. So, Dr. Sushila Rani is the past president of Bangalore Society of OPG. She is the present director of Manjushri Specialty Hospital, and also she is the chairperson of Postgraduate Forum of Bangalore OPG Society. She has also been the scientific chairperson of AICOG 2019 and national advisor of AICOG 2020. So over to you, Dr. Sushila Rani.
Thank you. Thank you, Prerna, for that introduction.
Most welcome, Doctor.
I'll just share my slides. Yes. Happened. Yes. Yeah, I hope it is visible. Yeah.
Yes.
Polycystic ovary syndrome is a kind of a syndrome which involves almost all the specialties and especially the gynecologists, and it remains an enigma. We could have many days of discussion on polycystic ovary syndrome, yet not arrive at the correct way, correct modality of treatment or the diagnosis or what investigations need to be done. When it comes to the adolescents, polycystic ovary syndrome poses a different kind of challenge because that is a period when a girl is going through her pubertal changes, and these changes by themselves contribute to a lot of confusions in arriving at the diagnosis of polycystic ovary syndrome. Not only that, managing the treatment aspect of various problems that happen during this time are not the same in adolescents, and therefore these also pose a challenge. So, to discuss these challenges in the diagnosis and treatment of polycystic ovary syndrome in adolescents, we have with us our own president, Dr. Tejavati GV. She is a president of Bangalore Society of Obstetrics and Gynecology 2021. She heads the unit of OBG department at Bhagwan Mahavir Jain Hospital. She's a consultant at HBS Hospital and Motherhood Hospitals. Not only that, she is an undergraduate and postgraduate teacher as well, and this she has been for more than 18 years. Dr. Tejavati has contributed several articles to Foxy Focus and chapters to various books. And I would say that she has been the main pillar of the postgraduate teaching program that happens annually in Bangalore Society of Obstetrics and Gynecology, popularly known as the BSOG CME. And she is one of the main pillars of BSOG CME and for its success so far. Now, we'll get on to the case. Welcome, Dr. Tejavati.
Thank you for that nice introduction, and good evening to all the participants. And it's nice to start our, the chat show or the academic sessions with the Omnicurus, and we are looking forward to many such shows so that all the consultants from different part of the country can be updated regarding various topics. Thank you, Dr. Sheila.
Yeah, it's wonderful. This is more like a chat show that we are going to have, where we are going to have a discussion about adolescent PCOS, the kinds of challenges that it poses for the diagnosis as well as the management. Dr. Teja, here's a 17-year-old girl who presents with irregular, infrequent periods since 1 year. The age of menarche is 12 years, and she also has severe acne, not responding to topical therapy, and this is causing some embarrassment. History of excessive weight gain in the past 6 months with inability to lose gained weight. She has an abdominal ultrasound already done. It comes with a report which says normal appearing uterus with bilateral normal ovaries. Specifically, there was no evidence of polycystic ovaries. Now, Dr. Tejavati, do you think this girl is having polycystic ovary syndrome?
We see, several cases, of this kind in our routine OPD, on and off. And in this case, I would, like to brief a few points. Like this girl who's 17 years and has had menarche at 12 years, that is about 5 years post menarche. And she has irregular periods once in 60 to 90 days, and along with that she has acne which is not responding to topical therapy. So I think these two features, that is irregular in menstruation and acne, which are ovulatory dysfunction and hyperandrogenism, she has both these features. And I would definitely give my diagnosis as PCOS in this case. I wouldn't definitely look at her ultrasound at all in this particular girl.
Yes, when you say irregular cycles, Dr. Teja, because quite often irregular cycles are very common in the adolescent age group. You see a pubertal girl and you find that her cycles are not monthly like we see in an adult. When would you call it as an irregular cycle in an adolescent to call it as a PCOS? When is this irregular cycle not normal? That is what I want to know.
Usually, after the menarche, during the first year after menarche, generally most of the young girls have irregular periods. That is because of the immaturity of the hypothalamo pituitary ovarian axis, which takes some time, to get used to this new job. So the first year, the cycles are irregular in, majority of the young girls. But after first year, up to 3 years, if they have cycles anything less than 21 days or more than 45 days, then you definitely call it as abnormal. And after 3 years, up till perimenopause, if they have cycle less than 21 days and more than 35 days, there again you would say that it is abnormal. Other than that, any one cycle of 90 days, that is 3 months, in a girl who is menstruated more than, had a menarche of more than 1 year, again, there again you would say abnormal. And if she has not attained menarche at all, up to 15 years, but then she has had breast development 3 years back. So in these cases, I would say the cycles are abnormal.
Wonderful, Dr. Teja, because this is one main point of concern. When would you call an irregular cycle as abnormal? When a regular cycle is actually a part of adolescence. So we now have appropriate definitions to say when it is irregular. Dr. Teja, you will agree that acne, hirsutism is all a part of growing up, especially among adolescents. Acne, hirsutism is all very common features. Now, when would you call this girl as having androgen excess? Like, to put it as PCOS, when would this acne and hirsutism actually become a state of androgen excess?
Yeah. As you said, mild acne and hirsutism is quite common in this adolescent age group. When it becomes, moderate to severe, that is, if she has acne, facial lesions more than 10, and if she has hirsutism, the score, that is what is called as modified Ferriman-Galway score of more than 6 to 8, there again you call it as abnormal. That is, depending on the presence of terminal hair on the upper lip, chin, neck, upper abdomen, lower abdomen, chest, upper back, lower back, thighs, you give a score depending on no hair to excess hair, you give 0 to 4 score. And if the score is more than 6 to 8 in hirsutism, then you call it as abnormal. And if facial lesion, that is acne more than 10, there again you would say it is definitely abnormal or features of hyperandrogenism. And
So
that
I gather
calls
that
for
any severe form of acne, any severe form of hirsutism in an adolescent, you won't just call it as something happening because of pubertal changes. It is something more than that and probably contributes to androgen excess. Having said that, Dr. Tejavati, we hear even this girl, for that matter, had come with a report saying that there are no features of polycystic ovarian morphology. What exactly is this PCOM, that is polycystic ovarian morphology, etc.? And do you think it is important in an adolescent girl?
Yeah, see, generally nowadays, even before they come to us, no, they would have taken a scan, and there it will be written as polycystic ovaries, and they come to us with that report. So we need to differentiate, very clearly whether we have to look into that picture or not. So polycystic ovarian morphology is when you do a transvaginal scan, and when you see the number of follicles more than 20 in one ovary, or if the ovarian volume is equal to or more than 10 ml, then that is, you have to rule out any cyst or corpus luteum or a dominant follicle. Then you call it as abnormal. On abdominal scan, because many times it may not be possible to do a transvaginal scan in young girls. So when you do a trans abdominal scan, the ovarian volume only is taken into consideration. So there, if the volume is equal to or more than 10 ml, and it is very difficult to count the number of follicles on transabdominal scan. So you take the ovarian volume, and anything more than equal to more than 10 ml, you label it as abnormal. And I would again emphasize here that to diagnose PCOS, the ultrasonography is not recommended in this particular age group. Up to 8 years post menarche, ultrasound is not necessary to make a diagnosis of PCOS.
Yeah, I understand, because in adolescent, the multifollicular ovaries can look like a polycystic ovary, and therefore one can easily mistake a multifollicular ovary to a PCO morphology, and then put her out as saying having polycystic ovarian syndrome. Thank you for that clarification regarding PCOM. What are the difficulties in diagnosing PCOS in adolescents, Dr. Teja?
Yeah, there are many challenges, especially in this particular age group, adolescent, because the first thing is about regularity of periods. Periods are irregular in the first year in almost 85% of the adolescents. And when it comes down to third year, it is as high as almost 60%. And in sixth year, it's about 25%. So this, incidence of irregularity, menstrual irregularity is there in the adolescent group. So there it's difficult to say whether she's PCOS or not. And then coming to acne and hirsutism, because of anovulatory cycles in this group, there is definitely more LH and more androgens. So there are features of hyperandrogenism like acne and hirsutism. So it's really challenging for one to make a diagnosis of PCOS in this particular group, and more so with ultrasonography of showing that PCOM, which is quite common almost in 30-35% of the adolescents. You have this picture, so it's very difficult to diagnose. And sometimes, even in contrast to this, girls having pakka features of polycystic ovarian syndrome, they may have scan showing absolutely normal morphology. So that is the reason it's really challenging, or we face difficulties in diagnosing a PCOS in this particular age group.
Yeah, that's right. Menstrual irregularity is a part of pubertal change. Androgen excess is a part of pubertal change. PCO morphology is a part of pubertal change. So these are the three main features based on which we make a diagnosis of PCOS. And these features cannot be used as well as we do in adults in a case of adolescent. And there lies a challenge in diagnosing PCOS in adolescents. Having said that, Dr. Teja, supposing we did have a 14-year-old girl, say a 14-year-old girl comes to you with cycles which are about once in 2 to 2.5 months, and she says the bleeding is heavy and it lasts for about 2 to 3 weeks. She says she has attained menarche at 12 years, she has mild acne, and she says she has recently gained almost 7 kgs in 1 year. You know what, with the lockdown, etc., etc. would you label this girl who is having irregular cycles and who has gained about 7 kgs in 1 year and who has got mild acne as having PCOS? Would you label her as PCOS?
No, in this case, she is about 2 years post-menarche, and she has irregular cycles, which are about 2 to 2.5 months, which is definitely abnormal, because we said anything more than 45 days is abnormal. But then I wouldn't label her as PCOS because she has mild acne and gained weight. But I would definitely keep a watch on her. And, I would say she's at risk of developing PCOS, not really having PCOS.
So when we say at risk, we treat her like almost having PCOS, as having
Yes.
PCOS, but we keep her under observation and we do not label her as PCOS, right, Dr. Teja?
Yes, definitely.
So that's what we say about PCOS at risk, not PCOS, but at risk of PCOS.
But then one more thing I would like to stress here is I would like to reassess her, at the end of 3 years for menstrual irregularity. And then if I want an ultrasonography, then I would wait till 8 years. So menstrual irregularity at 3 and then scan around 8 years post-menarche. That would be the ideal time to definitely, put a diagnosis of PCOS there.
Yes, good. Dr. Tejavati, in your clinic, what are the common presenting symptoms in an adolescent girl who comes with PCOS? What are the common presenting symptoms?
Most of the time, what I have seen is menstrual irregularity, either amenorrhea or oligomenorrhea or heavy bleeding. 70% of the cases, girls come with this problem. And I have seen girls coming with increase in weight gain also. Weight gain, which is quite common in around 60%, and the acne and hirsutism. Acne is more prominent nowadays, in the sense a feature of hyperandrogenism. Maybe here they may not be much worried. The acne on the face, will bring them to a doctor, asking for remedies, because that is the thing where everyone looks at and they feel embarrassed at those acne. So they definitely come for that particular reason.
Wonderful. Wonderful. So the most common symptom you said are menstrual irregularities, and they can also have acne, hirsutism. And then, yes, this is the time when they put on weight also during the period of adolescent. And normal cycles can be seen in about 20%. Now, in this particular girl, Dr. Tejavati, she has come to you with irregular cycles, etc., etc. And her last period was about say 2.5 months back. You've done a pregnancy test and it's come negative, because all adolescent girls these days, you better check out for pregnancy when they come with a period of amenorrhea. Now, having said that, what are the investigations you would order in terms of PCOS for this girl?
That is in the 17-year-old girl.
17-year-old girl. Yeah, 17-year-old girl, not the other one. Yeah.
Yes, I would like to have a list of investigations like, say, TSH, thyroid, and the FSH is not really required, because only in girls having amenorrhea for a long time, there I would like to get FSH LH done. Otherwise, TSH, prolactin, and the androgens, because we are basically worried about hyperandrogenism. So I would like to get a total testosterone done. Though they say free testosterone is more accurate, but then more useful to know how much of problem she has. But then it's not really accurate to get a free T, because it's very difficult to get a highly sensitive report. So total testosterone, or you can calculate the amount of free testosterone.
Yeah.
And you need the high quality assays, validated high quality assays when you are asking for androgens, which is liquid chromatography and the mass spectrometry, they say, is very, very accurate. So you'll have to look for, you can't get these tests done in the the regular normal labs.
Yeah, what you say is quite important, because before we label as having a high testosterone, we have to get it done through appropriate methods. And since free testosterone is not available and it is not accurate also, we would rather get a total testosterone done, get an SHBG level, and then calculate the free testosterone. And based on that calculated free testosterone, you will say whether she's having biochemical hyperandrogenism or not. Yeah, like you said, most of these girls, we do get a TSH level done, maybe a prolactin. And if we find that the androgens are very high and the testosterones are normal, in such cases, probably you would get a DHEAS done. And DHEAS is, of course, of adrenal origin. So when there are signs of androgen excess and you find that the testosterones are all normal, then you would probably look at other sources of androgen, that is like adrenal. That is why you would get a DHEAS done, and a 17-hydroxyprogesterone to find out if there is any non-classical
non-classical CH.
Now, once the PCOS is confirmed, like once you have made a diagnosis of PCOS, I think all girls, adolescents or otherwise, should get an oral glucose tolerance test and a lipid panel done.
Yeah, very important, because that will give us an idea of how, whether the metabolic thing has come in, and we need to pay importance to that part of the problem also.
Dr. Teja, like you did mention that we will get testosterone levels and all done. When there is evidence of clinical hyperandrogenism, that means, she has got acne, really bad acne with more than about 15-20 pustules and comedones on her face, or she has got gross hirsutism or severe hirsutism. Would you still want to get the testosterone levels done?
No, not in all cases. If there are clear cut, no, we can definitely go with clinical features, but only where you have a doubt and you are very unclear, whether she has. In those cases, a not clear picture of, hirsutism, or, in those cases, maybe to confirm your thing, you can get it done. Otherwise, clear-cut evidence of hyperandrogenism, I don't think you need to, look, get a free testosterone done.
Yeah.
And they say the testosterone, if it has to be done, better to get it done, in the early follicular phase and morning sample, because that is the time the values are correct. It doesn't come with the physiological rise in testosterone.
Yeah. I understand that. Also, another reason why you would probably get testosterone levels done is when there are not just signs of acne and hirsutism, when there are other signs of virilism for that matter. Say, supposing there is mild clitoromegaly, or supposing there is a change in the voice, well, you have a little suspicion that this androgen could be coming from some other source. So then probably you would want to get all the androgens evaluated. Thank you, Teja, for that. And see, the entire panel that you have mentioned, you have not asked for AMH. In an adult, we sort of now use the AMH for the diagnosis of polycystic ovarian syndrome. Would you not want to get an AMH done for this girl? Wouldn't it?
Though AMH is, no, though AMH is definitely increased several fold in adolescent PCOS, but it is not recommended for a diagnosis of PCOS. So I wouldn't definitely not ask for an AMH.
You will not want for an AMH.
No.
Because AMH, we don't have proper cutoff levels of AMH in an adolescent. Okay, now we have diagnosed PCOS. What would you want to do next, Dr. Teja?
The next very, very important thing is counseling. I would like to counsel the girl along with the mother. Most of the time, the mother comes along, not anyone else. So I would like to counsel the girl along with the mother. And I would like to, not scare her, but I would like to tell her this is one of the common problem, with most of the girls nowadays, because of wrong kind of, food habits and not exercising. So that is the reason. And I would also tell her how it can have, effect on her future, short-term and long-term problems. If she doesn't get rid of that, what all problems she can have immediately and long-term. I would like to explain to her and the significance of following a proper diet, exercise, and make sure that she understands the severity of this problem, and let her decide how much of commitment she has to show in following her diet and doing her exercise. So I would definitely, and I would also tell the mother about the diet and the kind of food she has to prepare at home, and make sure that more all of them eat the same
Entire
kind of food.
family eats it.
Yeah,
Make sure
yeah,
the entire family eats it. Yeah.
yes.
That's wonderful, Dr. Teja, because counseling is very important. I would start with finding out first how much she knows about PCOS, because quite often these girls tend to have a very wrong notion of PCOS, or they have absolutely not much idea about it. So first I'll find out what she knows about it, and then I'll go on, probably, like you said, to explain about the short term consequences, etc., etc. Now, Dr. Teja, we know lifestyle changes are the important foundation stone in the management of PCOS. What changes would you suggest for an adolescent with PCOS? It's easy to talk to an adult for that matter. For an adolescent, what is the kind of lifestyle change that you could suggest?
No, first of all, I would ask her what she does every day. I mean, what she's been doing the last few months, for having, had this problem.
Daily
Then
routine.
I would like, I would like to counsel her regarding. I won't tell her you'll have to start, dieting and stop eating and all that. I would like to tell her what all foods she has to avoid. Avoid the junk food, and no crash dieting, and to time her meals properly, and the kind of food she has to take, what she has to avoid, what she can take more, and then the exercise, what she's been doing so long, regarding her exercise, no sitting in one place and watching TV and playing on the system and all those things. I would rather ask her to on the music, and uh, do a vigorous dancing every day, maybe for about half an hour to 1 hour, and be active. So no sedentary lifestyle. That will be my definite advice to her.
Ah, that's wonderful. That's wonderful, Dr. Teja, because I'm sure you're not going to be her great friend. If you have to put it across to her, you need to be very, very diplomatic. And I'm sure this should not be, this should happen with the family around. Counseling should happen to the family, not so much to the girl, because you can't tell the mother, or mother cannot tell the girl to go and exercise, whereas they do nothing about it. The entire family has to inculcate the whole habit of a change diet or a healthy diet. So it has to be a family lifestyle change, and not just the lifestyle change for the girl as such. That was very well put across, Dr. Teja. Now, what are the exercise recommendations you would give this girl?
We have exercise according to their weight, like say light exercise which is less than 3 metabolic equivalents, and then you have moderate, you have vigorous. So depending on what you're doing, we can step up. Suppose if she's doing the light one, you make her do the moderate intensity workout, and you should tell her 3 hours per week. You want the prevention of weight gain, you have to do at least 3 hours per week of moderate intensity exercises, both the muscle strengthening and the bone strengthening exercises. And if she's gained a little more weight and wants to lose, I mean the weight gain is really bad, then her exercise has to be stepped up to moderate to vigorous. That should be about at least 2.5 hours on 3 consecutive days per week. So that would be whatever she's doing. I mean, it's not that she has to go to a gym and exercise. The vigorous activity can be, bicycling and walking briskly. All those will come to the vigorous thing. So at least 2.5 hours on 3 consecutive days, and it should involve both the muscle strengthening and the bone strengthening exercises.
That is resistance exercises you're talking.
Yes. Yeah.
I fully agree with you, Dr. Tejavati, on this, because quite often when you tell, doctor, I go for walks, is what they say. And we need to tell them that walking is good. It is good enough to prevent weight gain. But if they have to really lose weight, then they have to do brisk walking and for longer distances. Brisk walking at a particular speed and for longer distances, only then they can expect any weight loss. With a regular routine walk that they do for short distances and not such a brisk pace, they are not likely to lose weight, because this is what they think, that they are doing it, but weight loss is not happening. Now, yes,
we should definitely, tell them to minimize the sedentary activity,
definitely, yes.
Yeah.
More than, as much as exercise is important, we should definitely ask them to cut down their sitting time, whether they sit on the sofa or whether they sit on the chair, whether they look at the mobile or the computer or at the TV. Their sitting time should be cut down enormously. And definitely, this can really contribute to their weight loss. Yes, now that we have spoken about lifestyle, Dr. Tejavati, especially with regard to adolescents, I also wanted to mention that, games, this is the age where they can participate in a whole lot of games, either badminton or shuttlecock, or girls who are into dancing. They can, instead of actually going to gym and losing weight, they could engage in such physical activities which gives them a lot of pleasure, and which can at the same time improve their health. It can improve their bone health as well. So they can engage in games for at least 60 minutes a day, and that will help them enormously in regularizing bring in that kind of benefit that we would expect in a girl for PCOS. Now, this girl with irregular cycles, how would we go about regularizing her cycles?
Yeah, in this girl who's 17 years, I would like to, start her on a combined estrogen progesterone pill, which is, the estrogen containing pill, about 30 micrograms, and one of the second generation progesterones like levonorgestrel, norethindrone, or norgestimate. One of the second generation, I would like to start them on cyclical hormones, so that they start getting their cycles regularly. And in this group, yes, I can give it to them for about a year. But if it is a younger age group, maybe I would think of only stopping her problem. Suppose if she has a heavy menstrual bleeding, I would like to give her only progesterones to stop the bleeding, so that she will have a regular non-bleeding interval. I wouldn't like to start her on OCs in a younger age group. But in this 17-year-old girl, definitely my option would be one of the combined estrogen progesterone. One of the second generation progesterone would be ideal for these girls.
Yeah, like you said, estrogen has an effect on epiphyseal closure, and therefore there is a lot of concern in giving estrogens to young adolescent girls who are still at a growing age, where the bones are growing. Therefore, according to the PCOS guideline from the Indian Fertility Association, the expert panel has suggested the use of only low-dose combined oral contraceptive pills, if at all we are using, and we have to use it for short periods to attain menstrual regularity. Like you said, Dr. Tejavati, ideal would be to use progesterones to control the bleeding, and the kind of progesterones that could be used for managing the bleeding would be something of norethisterone kind, so that they are better at managing the cycles than the other kind of progesterones. Whereas for an adolescent who is over the age of 16 years, that is where you can use a combined oral contraceptive as well to manage her cycles and her regularity. Now, how can we manage the kind of acne that she's having? Supposing acne is a problem, then how would you manage her acne, Dr. Teja?
No, acne, again, we have stressed here the importance of lifestyle modification. There's nothing to replace her diet and exercise. Along with that, if acne is really bad, then I would like to, go for the combined, estrogen progesterone pill, which I just mentioned. But if acne is really bad and we have to basically treat that, maybe my second line of sun would come in, estrogen along with the cyproterone acetate, that is CPA, which is good in controlling acne and hirsutism. So if they have both, then that combination would be better. But otherwise, my first line of thing would be again estrogen and the second generation progesterone.
Suppose,
And there are other treatment also, like the topical form of treatment with retinoids and antibiotics and the salicylic acid preparation. And if it is bad, if it is moderate, a little bad, then maybe the systemic, which I just mentioned, the combined pill, or the second line with the CPA. That would be my, and the oral antibiotics also.
yeah. So actually, from our
Apart from the cosmetic and also, yeah.
yeah, from our point of view, from the point of view of gynecologists, we would choose the kind of combined oral contraceptive pill that we would give this girl. We would probably choose those which are less androgenic or not androgenic, those kind of progesterone. Maybe drospirenone, or for that matter, even cyproterone acetate could be in combination of ethinyl estradiol. So those would benefit her. Other than that, the rest of the treatment is usually given by a dermatologist who will take care of both the topical medications, and there are so many others in the management of acne that can be taken care of. What about hirsutism, Dr. Tejavati? Supposing this girl really did complain of hirsutism, what is the kind of treatment we could give from the gynecological perspective?
Yeah, here again, I said no, the same lifestyle modification, and along with that, the COCs we can add with the CPA, and we have anti-androgens spironolactone, which is quite good for hirsutism. But in case she may have irregular periods with this, so in that case, a combination of the estrogens along with the CC along with the spironolactone would be a better combination for hirsutism. And we do have the other epilation, waxing, and laser therapy for this hirsutism, where the dermatologist would be the best persons to handle this issue.
Yeah.
More than the gynecologist, we would usually go with the combined pills.
Yeah, probably, yes, the kind of COCs that we choose is something that we need to pick up, like something with a combination of drospirenone, or a combination of cyproterone acetate with ethinyl estradiol. Having said that, some of the anti-androgens like spironolactone also can be used, but these we have to make sure we don't use for more than a year. Because they have their own side effects. And then while on spironolactone, we have to make sure that the girl doesn't conceive by any chance, for that matter, because this has an anti-androgenic effect. And in case she has a female fetus, then in case she has a male fetus, then it can lead to feminization of that male fetus. Therefore, when spironolactone is being used, it has to be used very cautiously. Generally speaking, most gynecologists do not prescribe spironolactone. It goes to the territory of dermatologists, and they are the ones who prescribe the anti-androgens, and even topical creams like eflornithine also are quite useful these days. So that is what we would do probably when it comes to management of hirsutism. Now, we know that polycystic ovary syndrome is not limited to the current problems of menstrual irregularities, acne, hirsutism. We know that in the long term, it can give rise to a whole lot of problems, which includes type 2 diabetes. And because there can be a whole lot of changes in the lipid profile, it can give rise to cardiovascular problems and coronary problems, etc. In fact, polycystic ovary syndrome has also been linked to cancer in the long term. And they say that it definitely changes the quality of life for a woman. Like to be diagnosed with polycystic ovary syndrome and to go through the problems or clinical situations because of polycystic ovary syndrome, they can land up with a whole lot of problems. Dr. Teja, with respect to type 2 diabetes. Now, we mentioned earlier that when once we make a diagnosis of polycystic ovary syndrome, we do get few other investigations done, and compulsorily so. Just
Yeah.
let me know how you would screen her for diabetes.
No, OGTT is the best option if you ask me.
Hmm.
But otherwise, you can get an FBS, fasting blood sugar, and a HbA1c, at least that, because that can be done at any time.
Yes.
OGTT means they'll have to, come on an empty stomach, follow certain protocol, and you'll have to wait for 3 hours. So sometimes they may not come back. So when they have come, they can just give the blood sample for, say, HbA1c or a RBS, so that at least you will know their glycemic status, what you need to do. And that is one thing. And apart from that, yes, lipid profile also is very, very important. Lipid profile also is important, so that you need to have that as a baseline and its impact on the cardiovascular problems.
Yeah.
Yes, as far as cancer is concerned, what you were saying that yes, gynec cancers, the incidence of endometrial cancer is definitely increased, much higher when you compare it to non PCOS group, because of the number of anovulatory cycles they have and exposure of the estrogens onto that endometrium. So definitely the incidence of endometrial cancer is more, and you'll have to keep a careful watch on these patients, especially along with obesity and hyperlipidemia. Whereas the other cancers, ovarian cancers and breast cancers, a lot of studies have been done, and it's been shown that there's not much of a difference, statistical difference between the PCOS and the non-PCOS group.
Yeah, yeah. I found that in my clinical practice, quite a few of the adolescents who come with their menstrual irregularities also show a slight tendency towards hypertension. So even as I check their blood pressure, of course, there can be a lot of white coat hypertension, etc., etc. But then having said that, hypertension is also one of the significant clinical finding in many of these girls who comes with, many of the adolescent girls for that matter, who come with PCOS. I don't know what your experience is about this, Dr. Tej.
Definitely. I also seen BPs of 140/90 in a girl of 15 years old, and their sugar showing, more than 100, a fasting level. So definitely, it is very, very important for us to screen these girls for, sugars and lipid profile.
Dr. Teja, um, do you think the prevalence of polycystic ovary syndrome has increased in the adolescents in the last couple of years? Like in your clinical practice, I'm sure you've been in practice for a long time now.
Yes.
Have you seen an increase in the incidence of polycystic ovary syndrome
A
in the recent?
huge, a huge, I wouldn't say just a normal, you know. As when we were postgraduates, we have never seen these cases. This last 10 or 15 years, I think the PCOS incidence has really gone up. And now with this lockdown, no, every alternate girl who walks in, comes with a problem of menstrual irregularity and increase in weight gain. So it's really very, very common. And I think it will keep on increasing with the kind of lifestyle we are following. It is definitely going to increase, and we have to keep a careful watch on these and counsel these young girls, because they're only 15, 16, and so much of weight gain, so many problems. So I think it's our duty as gynecologists to counsel them as much as possible, and make sure to tell them what weight gain does to them, both short term, that is reproductive disorders, and long term, the metabolic disorders.
Yeah, I agree with you. Even school going girls, for that matter, they put on such weight gain very rapidly. And you find that when you go through their daily routine, you find that they hardly have any physical activity. They do have a compulsory physical training class, PT class, in the schools. Now that is according to the curriculum for the high school and the primary school. They have definite hours designated for physical training. But even during those times, you will find the girls all huddled in one corner, either chatting up or trying to finish their homework at the time when they have to be actually playing around. And somehow sports has not been encouraged to that extent at all amongst all the girls, for that matter. And therefore,
Another important thing I would like to add here is the psychological problems, the anxiety and depression in these young girls, very, very common with the weight gain. They're not really, free, walking around or wearing dresses, looking at the mirror. So that is also a big problem, the depression and anxiety, and we need to address these issues also in these young
yeah,
girls.
I certainly agree with you. It brings down their level of confidence whenever they put on weight, and when they have acne, hirsutism, etc. On top of that, if they have irregular periods, it makes them feel very, very unsure of themselves. And
Yes.
that's a period. Adolescent is a very, very sensitive period as far as
Yes.
emotions are concerned. And this, it's a very vulnerable period. And at that point of time in their life, they do not get positive feedbacks regarding their health and status, etc., then they can easily have go in for depression,
It
anxiety,
can,
etc., which can
can
affect.
damage their future.
Yeah. So
Really.
handling adolescent PCOS is very challenging, because you're not just looking at their problems as of now, whether it is menstrual irregularity or acne or hirsutism. You're also looking at the emotional impact it can have on these girls, because it's going to be a long-term impact. And on top of that, you also need to make them aware about the long-term implications of this particular problem. And therefore, it is important that we handle these women very, very carefully. Yes, that is how do we go about bringing an awareness about PCOS, Dr. Tejavati, from the
I think
society point of view, from a personal point of view? How can we bring in the changes or an awareness about PCOS, so that our girls are better prepared and don't get into this kind of an environmental change that brings on PCOS amongst adolescents?
no, I think here, no, every place is important. At home, in schools, colleges, place where they work, or where they spend their time. I think everywhere, no, that awareness of health and diet and exercise, should be brought in, so that, no, wherever they go, if such awareness is there, no, that will be taken seriously, at least to some extent. They absorb that kind of information and make sure, no, they follow. So right from the at home and the schools, colleges, place of work, I think each and every place is very important to have some kind of a poster or some kind of TV information, or some the thing which they give out, you know every form of awareness can be made available.
Yeah, I agree with you, Dr. Tejavati. Now, I know COVID has gained so much importance that you ask a person who sells on the cart on the street, and he's able to tell you about what COVID organism is, what is the kind of vaccine, what is the kind of protection, what is the positive rate, what is RT-PCR. So much information they get about COVID. Whereas I definitely know and understand that polycystic ovary syndrome can cause equal damage or even more, for that matter. But the
Yes.
awareness about this is so very lacking. And that kind of an awareness that we are trying to create for diseases like COVID also has to come in for problems like
Yes, very true,
PCOS,
very true.
which is very important. And this we can do by having walks for PCOS, having talks and write-ups about PCOS, and then giving articles on PCOS in the schools and colleges, etc. We should have luminaries who come and address this particular problem about PCOS. Have a actor female actor who's very prominent to come and talk about PCOS, then it sort of attracts the public, it creates a curiosity, and they will want to know more about it. And that is what is required. And if they can emphasize on lifestyle changes, that would make a world of difference.
Yes,
If you
nothing
about
like that.
lifestyle changes in the adolescents and in all population for that matter, if the entire family runs, then there won't be PCOS.
Yes.
If the entire family is into exercise, then the chances of PCOS becomes reduced. If their entire family is eating healthy, then the chances of PCOS becomes remarkably reduced. So, and it can be handled. So these are the kind of changes that we would want to see in the society in general. And yes, and that can bring about a remarkable decrease in the incidence of PCOS. This kind of an awareness can bring about a whole world of change in the PCOS. Thank you very much, Dr. Tejavati, for this wonderful conversation that we had on adolescent PCOS. We would now look into the kind. I'll stop sharing the slides.
Thank you, Dr. Shushila, for that, nice flow of questions and your inputs. It really made the session very, very interesting.
Yes. Prerna, I am not able to see any questions on the chat show.
Yes, doctor. So we have not received any questions so far, but we have received a good number of feedbacks from the audience.
Yeah.
So as of now, there is no question and answer, doctor, to be done.
Yeah.
So
I suppose that that means either we have done a job extremely well, or probably they must have gone off to sleep listening to us.
No, doctor, we have received a good number of feedback, good number of feedbacks on your talk and all. That is actually very good feedback we have received. So, doctor, we would really like to thank you, Dr. Shushila Devi and Dr. Teja Suti, for your valuable insight on this interesting topic. So, this brings us to the end of the webinar. And we would like to thank you all the doctors for attending this webinar. Also, we'll be uploading this recording on our Omnicurus website so that all the fellow doctors can watch it again and learn anytime from anywhere, doctors. Also, do follow Omnicurus on Facebook and LinkedIn to stay updated on all our upcoming webinars. So thank you all the doctors and have a very good evening ahead.
Thank you,
doctors.
Thank you, Prerna and Omnicurus.
Thank you so much, doctor. You're most welcome, doctor. Have a good evening.
Good evening.
Yeah, thank you.